Let's continue our lecture of anti-rheumatoid drugs. This is part 2 of the lectures. We have already discussed the methotrexate, and now today we will discuss the azathioprine. This is another immunosuppressant. So when it is given to the patient, it goes inside the body and it is converted into the active metabolite known as 6-mercaptopurine, and this conversion is carried out by the enzyme known as thiopurine methyltransferase. Once the 6-mercaptopurine is formed, it causes the purine synthesis inhibition. It also causes the inhibition of the cell-mediated immunity and also alters the function of T cell and natural killer cells. And all this action of azathioprine leads to the suppression of inflammation in rheumatoid arthritis. Here I want to tell you that azathioprine causes remission only in small percentage of patients of rheumatoid arthritis. Also, it has the steroid sparing effect. When we cannot use the steroid or adverse drug reaction occurs with the steroid, so we add the azathioprine to the patient. So it has steroid sparing effect. It is usually not combined with methotrexate. The azathioprine is usually not combined with methotrexate, and the dose of azathioprine is 50 to 150 mg per day. So this was about the azathioprine. Cyclosporine we are not going to discuss here because it is very rarely used in rheumatoid arthritis. Now we will take another drug, that is the sulfasalazine. It is another non-biological immunosuppressant. So about the sulfasalazine, when it is given to the patient of rheumatoid arthritis, it goes inside the gut and it is activated by the bacteria, and it is converted into the sulfaparadine and 5-amino-salicylic acid. This 5-amino-salicylic acid has anti-inflammatory activity in the bowel. It acts locally in the bowel, and that's why it is useful in ulcerative colitis. Besides it, sulfasalazine is also converted into the sulfapyridine, and this sulfapyridine is absorbed in the circulation, and it causes the suppression of the production of superoxide radicals, and cytokine production is also suppressed, and this action is useful in rheumatoid arthritis. And the efficacy of sulfasalazine is modest, and in 10% cases with the use of sulfasalazine we have seen neutropenia and thrombocytopenia. Besides, it also causes the hepatitis, and it is also the second line drug for mild cases of rheumatoid arthritis. And this sulfasalazine is usually combined with methotrexate, and the dose is 1 to 3 gram per day, which is usually given in 2 to 3 divided doses. So after the sulfasalazine, another DMARD is the chloroquine and hydroxychloroquine. This drug causes remission only in 50% cases with rheumatoid arthritis, and this remission takes about 3 to 6 months, and it has relatively low toxicity when compared with other DMARDs. And I would like to tell here that bony erosions are not prevented with the use of chloroquine and hydroxychloroquine. Exact mechanism of action with the use of chloroquine and hydroxychloroquine is not known, but it has found to suppress the interleukin 1 level, thereby inhibiting the production of B lymphocytes. Other proposed mechanisms are antigen processing is interfered with, lysosomal stabilization and free radical scavenging are the other proposed mechanism with the use of these drugs. For rheumatoid arthritis, this chloroquine and hydroxychloroquine is usually given for long periods of times, and that's why they accumulate in very tissues of the body, especially the melanin containing tissues. And the most disturbing effect is seen in the retina. It causes retinal damage and corneal opacities. However, this side effect is less seen with the use of hydroxychloroquine, and that's why hydroxychloroquine is preferred over chloroquine. Other adverse drug reactions which are seen with the use of chloroquine include rashes, graying of the hair, irritable bowel syndrome, myopathy, and neuropathy. These chloroquine and hydroxychloroquine are usually given for mild non-erosive disease when only few joints are involved in rheumatoid arthritis, and this is usually combined with methotrexate and sulfasalazine. The dose in case of chloroquine, it is 150 mg base per day. For hydroxychloroquine, it is given as 400 mg per day for 4 to 6 weeks, followed by 200 mg per day for the maintenance. Now another DMARD is leflunamide. Leflunamide is an immunomodulator, and it inhibits the proliferation of stimulated lymphocytes inside the body. Thereby, it reduces the symptoms of arthritis, and also radiological progression which is seen in rheumatoid arthritis is also retarded with the use of leflunamide. The onset of benefit is very fast with leflunamide, that is, it is within 4 weeks the patient starts improving. And when we give leflunamide, it goes inside the body and converted into the active metabolite, which then inhibits the enzyme known as dihydroorotate dehydrogenase, and pyrimidine synthesis is inhibited in the actively dividing cells with the use of leflunamide. It also inhibits the production of antibodies from the B cells. The active metabolite in leflunamide has a half-life of 2 to 3 weeks. Therefore, it is given as a loading dose, which is 100 mg once daily dose for 3 days, followed by 20 mg once daily dose. And the adverse reaction which is seen with the use of leflunamide includes diarrhea, headache, nausea, rashes, loss of hair, thrombocytopenia, leukopenia. It also increases the incidence of chest infections and also increases the liver enzymes. It is not recommended to be used in children, pregnant women, and lactating mothers. Leflunamide is alternative to methotrexate. When combined with methotrexate, it leads to the hepatotoxicity. When it is combined with sulfasalazine, there is improved benefit is seen in rheumatoid arthritis. Another DMARD which are not used nowadays is gold. It is given as IM injection as gold sodium thiomalate. It has high toxicity. It causes hypertension, dermatitis, stomatitis. It damages the liver, kidney, and causes the bone marrow suppression. So it has gone out of use. Another gold compound is oranofin, which is less effective and less toxic, and it is being replaced by better drugs now. Now lastly, the D-pencillamine, it is a copper chelating agent. Its action and toxicity is almost similar to the gold, and it is no longer used nowadays.